I'm Don Dizon. I'm a professor of medicine at Brown University and director of women's cancers at Lifespan Cancer Institute. And with me is Tatiana Prowell. She is an assistant professor in the breast cancer program at Johns Hopkins Kimmel Cancer Center and is the breast cancer scientific liaison at the FDA. And welcome to Medscape Oncology Insights. And I am very happy to be here because the topic that we're going to talk about today is something that Tatiana and I have discussed on various social media platforms. And it relates to communication, particularly in an age where communication is not siloed, right. Where what we hear as professionals is what our audience hears and what our patients hear and what our caregivers hear. So Tatiana, what are your thoughts in terms of how oncologists talk today?
It's interesting. We all go to medical school and we're chosen based on grades and scores, but at least in part on our ability to relate to other people. Might be assessed through our personal statement or the interviews, but medical schools care about the fact that we can communicate. So they select for these people, and then they beat our ability to communicate out of us over the course of our medical training. So I'm always struck by how when I go back and talk to elderly family members, for example, I'll be trying to understand what happened with their medical situation in the hospital, and they'll tell me that they had blood poisoning, and I'll think, blood poisoning, and then I'll realize, right, that's bacteremia. That's what I used to call it. Yeah. Or I had double pneumonia, and that's what we call bilateral infiltrates. And so we teach people in medical school to forget how to communicate like normal people. And that's the first issue. I think the second issue is we have a lot of language that's baked into medicine that I think reflects a time when medicine was more paternalistic, where patients were not equals or partners, and that's still reflected in our language, and I worry that it has the ability not only to make patients feel disrespected, but also to actually influence our own thought patterns.
Right, and I think to pick up on that, this, I don't want to call it dehumanization, but the language of oncology that were instilled in us early in our fellowship is one that we just tend to adopt as second skins. And so we do talk to each other about, that cancer patient that you just had in that room, that ovarian cancer patient, how is she doing? It's all empathy, but we're really looking at people based on their disease.
Right.
And I think there was a time, right, when that was okay because you only got information through your doctor and your medical record wasn't something that patients could access. Right. But I think our colleagues don't necessarily appreciate that shift. I mean, I'm not sure. I mean, what is your impression in clinical practice?
I think that even now with our fellows and our residents who've grown up during a time where patients are really much more partners with us than they were when I trained, which was, I started medical school in 1995, so quarter of a century ago. It's sounds bad when you put it like that, right? But I think that
I won't say anything about that.
Right, thanks, I appreciate that. So, but even for people who are training now, they're still learning the language that we were raised on, right?
Yeah,
so we're saying the patient progressed, when in fact the tumor got worse.
Yeah.
We're saying the patient was a screen failure or failed their treatment. Yeah. When in fact, if anything, our process failed or our medication failed. We had a clinical trial that wasn't designed for the sorts of patients we see, and therefore the patient's not eligible for the clinical trial. But we call them a screen failure. I think it makes us feel better about ourselves. Or we say the patient failed treatment, and in some sense it kind of removes the responsibility from us as physicians or scientists that we still don't have adequate therapy for a lot of our patients.
Yeah, I think that's
actually a defense mechanism.
Well, on the one hand, it is a defense mechanism, but I think you're being generous. I think the other reason why that language works in our field is because I understand inherently what you meant when you say that patient failed treatment. I understand, and I'm assuming what you mean is, my concern is that, and I've written before how I've walked into a patient's room and said, this, you're failing this treatment and we need to move on. And I got the equivalent of an emotional slap in the face. Yeah. Because patients don't want to feel like they failed anything.
Absolutely.
And I think it's something that I've learned through social media. You know, that people actually do listen to that, even
Absolutely.
beyond their own personal experiences. So I'm wondering, have you had any exposures into that world that sort of struck you, on the social media?
You know, it's interesting. It's happened both on social media and in clinic, even in language that I wouldn't say is overtly disrespectful or anything, but just all the ways that we can confuse patients. For example, I've said a scan was negative and had a patient break into tears because she understood that to mean the results were bad.
Yeah.
That's what negative means.
Yeah.
Whereas I mean, your scan is all clear.
Yeah.
Looks great.
Yeah.
Right? So I think that there are ways that we can not be well understood, and some of those are offensive, and some of those are just failing to communicate well, failing to convey the right information. It's all failing to convey the right information in one sense or another. I've really appreciated so many patient advocates from the breast cancer social media world on Twitter calling these things out. And I'm sorry that I actually don't know which patient advocate this was, but someone said, I don't like how people keep referring to this as the disease. It makes me feel like I'm infested.
Yeah.
It was such an interesting word. And as I thought more about it, and we talked about this a little bit on Twitter, but it felt very antiquated. Like it was from a time when cancer was unspeakable because the prognosis was so poor. We're not even going to call it cancer. We're going to call it the disease. And we're going to say the disease progressed, right? And this is built into our language. We have this in the formal tools that we use to assess response to our imaging, right? So I think that when you have language that is so deeply ingrained in the culture of medicine and science, changing it is a lot of work. It's like changing your name.
Yeah. So I wonder, though, there are folks, when I've written about this topic of the language, they kind of roll their eyes and say, it's as if you're trying to introduce political correctness into the oncology world. And that makes me uncomfortable. What do you say to folks who might have that opinion?
So I think 2 points. So the first one is, frankly, our opinion about this doesn't matter. The patient's opinions matter.
Yeah.
So if we think that this is making some exceptional allowance to not hurt patients' feelings, well, we should.
Yeah.
If we feel like we're going above and beyond so that we're not misunderstood, we should.
Yeah.
So to anybody who objects to it on those grounds, I would say, I don't really care.
Yeah.
Because what matters is what the patients are hearing and what the patients feel when we say these things. That's the first part. I think the other part is we know that linguists have looked at this, for example, in languages that have genders associated with their nouns, that just a simple fact of language actually influences your thought. So, for example, if you take words like death, which have different genders in different languages. So death in German is masculine, death in Russian is feminine. And if you look at paintings by German and Russian painters that have personified death, German painters almost always paint death as a man, and Russian painters almost always paint death as a woman. There's no obvious reason for why that would be.
Yeah.
There's no reason to think that this is some sort of bias. This has nothing to do with political correctness. This is just a simple fact of how the language that we are taught from birth, and in the case of medicine, that's the language we're taught from our rebirth as medical students, actively influences our thought.
Yeah. So I
So
guess
it's interesting.
I think it is fascinating. Just the mere nature of not only a blame, there is no place for it, obviously, but the language we use can sometimes place blame. But also this notion of taking a concept and assigning it almost a gender is also really interesting. But I think the harder point, and this is where I sort of, hit a wall, is it can feel like changing the way we talk. It's almost as if you're fighting windmills, you know, because it's one thing to say in fellowship, I want us all to really think about how we're phrasing things so that this generation of up-and-coming oncologists won't talk about things the way I was taught to talk about things. But it's quite another thing to go through an annual meeting, whether it be the AACR or ASCO or any other thing, and see poster after poster, presentation after presentation, where the traditional PowerPoints come up. 70 patients were looked at, 30 failed screening, and then you go to the next, and survival. We haven't hit median survival yet, or a whole other a whole other language. You're an up and coming academic. What is our responsibilities, do you think, in terms of forcing or encouraging? I don't know which verb makes more sense, but encouraging the shift in language.
I think it's neither forcing nor encouraging as much as it's modeling.
Interesting.
Right? Think how much medicine is still an apprenticeship. We do what we see our seniors to us do, whether that's medical students looking at the interns, or interns looking at the senior residents, or residents looking at the fellows, and so on. So I think that part of it starts with just modeling the kind of world that we'd like to see. That I think is probably the most important thing. I think the other thing is we have to realize that this is a long process. And it's natural with all change for people to resist because it's unfamiliar. Doing anything not the way you're used to doing it naturally involves actual effort. And people are wired to resist things that involve actual effort, right? It's hard to get people to go exercise. Right? So, it's interesting. I remember sitting in high school and having a teacher say fireman. And one of my classmates, so this is, in the 90s, right, that I'm in college. This is the late 80s. One of my classmates say firefighter, a girl, say firefighter. And the teacher said, I have a better idea. Why don't we just say fire extinguisher? And I thought to myself, wow, what a takedown. But now when you say firefighter, no one blinks at that.
Yes, that's
true.
So
it's a long process. It might take decades. It might be the children of the people in medical school now. But the right language will end up winning. We just have to model it, and we have to be patient that we're not going to see the end of the work in our career lifetimes.
That's, in one sense, I agree with you that it's going to take a long time, but in another, it's discouraging that we won't. So right now, we have an audience. What are the 5 things? What are the 5 choices you would say instead of think about saying it this way? Can you think of 5 ways you would rephrase things?
I think the language of failure needs to go. We need to stop screen failure, treatment failure, and if there's failure, if we want to retain that word, then we need to flip the order so that the treatment failed the patient. The eligibility criteria failed the patient. So that's part of it. The failure language, I think, needs to go.
I totally agree with you there.
I think that I'd like to see subjects go, and that's difficult because we've got that language, again, deeply ingrained. We have offices of human subjects research.
Oh, interesting.
We've got that language deeply ingrained in regulatory standards and clinical trials, but I'd like to see that go. And I was so struck by Joe Sperano during the Taylor X presentation referring to the trial participants as volunteers.
So was I.
And he didn't even say participants, he said volunteers. And I saw in the whole row of people around me, it took me a second, but I watched in the row of people around me as he said it again, people being confused thinking, were these people who were assisting with the trial? They actually, it took them a few times of his saying it to realize he's actually talking about the people who are in the trial. But what a powerful choice of words. And as important as that, and a platform, and as important as that clinical trial was for the practice of breast cancer, that moment was the thing that I remember most from the presentation. And that moment was the thing that I heard the most people talk about after that presentation, and not only patient advocates, but my colleagues. So I think it makes the point that if you are in a position of prominence, you have an obligation to be thoughtful about your words. You have an obligation to model how it could be done better. So getting rid of subjects, which again is complex, and replacing that with volunteers or participants, something that acknowledges that these people who join our clinical trials are our partners in drug development.
And they did it voluntarily.
And they did it voluntarily,
Yeah,
absolutely. Yeah. And like all volunteers, it was a ton of unpaid work.
Yeah,
right?
Exactly.
A ton. So that's the second one. I think the third one would be, maybe this is not oncology specific, but maybe some of the language around obstetrics and gynecology. Things like estimated date of confinement.
Yeah.
I remember being pregnant and seeing that and thinking, estimated date of confinement?
Yep.
What on earth?
Yep.
So there's a lot of language, and that's hard to imagine that there are not gender issues there. But I'd like to see some of that language around relating to pregnancy go. Yeah. So that would be a third one. You know, I think the fourth one is it's not a term as much as it's a phrasing. And I'm guilty of this all the time, and I catch myself, which is, we say patients instead of people with.
Yes. Oh,
yeah. I made the decision to, my Twitter bio, since I started using Twitter, which was really about 1.5 years ago, had said serving cancer patients via clinical care, medical education, and so on. And I made the choice to change that to say serving people with cancer, which in Twitter, that requires a lot more characters than cancer patients. So this was a real choice. But I thought it was important to put the people first and the disease that they have second.
Yeah, I keep saying it's not an adjective.
It's not. Noun.
Yeah.
Absolutely. And I get it. It's shorthand. It's compressed. Sure. I understand why we talk like that. But I do worry that when we put the condition before the patient, that we're putting the condition before the patient in our minds. And we see that borne out in rounds where, people will say the pancreatic cancer, case.
Yeah. Or that cancer in bed too.
Yes, absolutely. And it troubles me a lot. So that's 4. What's 5? So much pressure because there are so many to choose from, and I only have one more. So I'm going to let you choose 5. What's 5?
Well, I think, the ones that I'm almost struck by, you mentioned earlier, and it's the whole notion around scanning and response criteria. Yeah. And, to break up something like, well, you didn't meet the criteria for a complete response, or you didn't meet criteria for this, or your disease is stable. I think that's also, there's a language we use in trials, which I don't think we can really change because that's how we understand each other. But the interpretation of it when it's written up, I think that deserves some mention as well. And I've known people who said, you were restaged and your restaging shows you're in CR, and it's just confusing. Yeah. So when you restage, that means you took me from a stage 2 to stage 1. Yeah. Or what does that mean? Or stage 4, but you weren't sure, so you checked, and now I'm a stage 2.
Right.
So it's just this combination of things which we use every day, and I think it's useful. We have to be able to interpret that. The language of oncology isn't one that people are born into. We had to learn it. We took 3 years to learn it.
Right.
And I think our patients deserve the same kind of time.
Yeah. I think the other thing, as I'm just thinking about this, I'm going through my own notes in my head, and the other piece I think is the language that disbelieves patients. So there's a lot of that. The patient denies illicit drug use. Right. So I have been very intentional since I've started thinking more about this to say the patient states she has never used illicit drugs. Yeah. Period. It's a statement of fact. And I think when we say denies, officially we mean the same thing. Yeah. Except that if you have a patient reading a note, which is common now in open notes.
Absolutely.
What do they think when they see that? Yeah. Do they think that I don't believe them? Because the truth is, it's very rare that I don't believe a patient who's saying, I've never used drugs. Yep. But when I write that, and I have written that thousands of times, I worry that it has a real risk of being misunderstood.
Yeah, and I think that's the reality of medicine today is patients have access to the records, patients have access to studies, patients have access to our presentations. We need to look at this through that lens, that this is no longer a closed society, and that network knowledge is the rule of the game.
So how do you do that now that you have patients accessing their clinical notes, clinic notes routinely? Yeah. Do you write your notes in different language to be more understandable to them? And do you find that takes you a lot more time because it's not the natural phrases you're used to rattling off?
Well, I'm going to answer that question by a plug, and that plug is every single oncologist should join Twitter because it teaches you to be succinct and clear in what you're saying.
True.
So, I have faculty who struggle with notes and how long they are because they're trying to explain things. And then I think if you use non-technical language, short phrases,
Mm-hmm.
the intention is there and
Right.
people can read that. But I do ask myself, am I comfortable with my patients reading this note?
Right.
And it's for that reason, I think, um, yeah, I think I'm like you. I'm a little bit more cautious,
Mm-hmm.
but also um, just just very clear about what I'm doing. I think our patients deserve that.
Absolutely. I agree.
Well, thank you so much for joining me,
Thank you.
Tatiana.
It's a pleasure.
It was great having you. And thank you very much for listening to this program. I hope it helps you in your own medical practice.